Good morning. It's about 8 o'clock in the morning on May 18th, 2020. This is Dr. Kirsty. I have been doing a little bit of reflecting and research around some of the arguments around wearing a face mask, not wearing a face mask, whether or not homemade face masks are effective in preventing the spread of COVID-19 or SARS-2. And I just want to say that for me, as somebody who practices or can't practice right now, my form of medicine, which is integrative medicine and craniosteopathy and cranial visceral work, due to the closures and the mandates within our state in New Mexico, I'm generally concerned about how my practice might look when I go back in, and also as somebody who teaches, what it needs to look like in the classroom. So I have a vested interest in finding good data, responsible data that can help inform, make policy decisions for best practices in the future, and aren't based on memes and social media. Even Snoops isn't always valid. And uses some discernment, and also is working with other professionals in our community to make best practice choices. So that is really my bias that I'm coming into with this, but I want to share what I've found. Our governor last week cited a article for the reason for mandating face masks in public. But there are some questionable pieces in that data if you start looking into what it's resourcing. Most of the research that's coming out now is not research. It's a synopsis or a literature review of research that has been done in the past before COVID-19. So understand that it's a measure of something else, influenza, SARS-1, not COVID-19. In fact, we just don't really have enough data yet. We're in that gray zone, that gray area. And so we really aren't in a position to be making policy decisions and mandates yet. We do not really understand the implications. That is going to take time. And I understand with a crisis, we don't have time, but there are hot spots that have been highly impacted with this, but there are also areas that are not really impacted. And right now we're being all treated the same. So I just want to point that out. But again, my true intention is to figure out how can we look at the research that has happened. And I just want to start the conversation instead of having us come from a place of us and them and such strong polarity, which is what I'm observing, at least in the social media platform and mainstream media and news. So I'm using my Zoom feature so that I can actually share some of the things. So I'm going to backtrack and go forward a little bit, but I want to show you what some of the articles say and keep it contextual. So I'm going to need my glasses because we're going to go into fine point reading. And so I'm going to start with just last night. Snoops has posted this, and you need to download the full article to really see. And this is a literature review. This is not new research. So understand that, again, this is one more of the literature reviews that's coming out. And you can download this from Snoops and take a look and scroll through and read through the measurements. But one of the things that I wanted to share with everyone is the transmission characteristics of COVID. And they are quoting the droplets, and most of us have heard that. But right here, the most common droplet size threshold has a minimum of 5 or microns to 10 microns. So that's what I want to post out here. And this is where the argument of wearing a face mask is coming into, is the prevention of the spread from somebody who's, quote, asymptomatic or symptomatic, and preventing the spread. Okay. There are some questions about the asymptomatic in the test, and that are being used, and there is a 14% failure in that testing. So be aware that we need to have a more whole systems approach in how we discuss this with everybody. So I'm going to stop that share for that article. You are welcome to dive into that on your own and find your own discernment. But I do want to share something else with regards to all of this. And I'm going to be flipping us around a little bit within all my screens. So here's something to think about. So what is a micron? I haven't really heard a lot of people talking about what a micron is. Here's the size of a human hair right here. Right, so then we have going down to smaller sizes, and here's a micron right here. So 5 microns or 10 microns would be 5 to 10 of that size, which is pretty big. COVID is 0.125 microns, the COVID-19 virus. So it is just above 1/10 of the size of this. And that's something that I want to point out. So droplets and the size of COVID are different because the COVID would be inside the droplets, right? But the actual virus itself is much smaller than a micron. The measurements used in a lot of the tests are down to, mostly they're around 5 microns for the validity of the mask. Some of them go down to 1 micron. And it depends on what kind of mask we're talking about. Cloth, homemade mask versus surgical mask versus the N95 mask. And those are all very different. And most of us who work in the healthcare field already know that N95 and surgical masks have the best outcomes in prevention. It's my debate really that I've been having with people is these homemade masks, and that's what's been mandated in our state. So let me go. So this was the article that was posted up on Snoops as an argument, and I'm questioning the validity of some of this, and I haven't like dove into all the little myriads and corners. This would take me several months of research to really look at all the data, but I think that's what is needed. We can't just look at something like this that's published online and say, oh, this is valid, this supports my argument. I don't even know personally these practitioners and scientists and researchers, so I can't even say who they are, where they come from. So it would take me quite a while. I started looking into another article last week, which was the one that was cited, oh, here, I was going to go into it through here. My apologies. From here, but it was actually what was cited by our state as the argument for making a policy decision on mandating homemade face mask or face coverings. So it's the Eikenberry article. And so this is the one that I started diving into over the last few days. And then somebody posted the Snoops, which is just another reiteration of a literature review. This is off review. So this is just drawing on past research around face masks and whether or not the use of them has efficacy. So that's what people need to understand. It is not a specific research study on cloth face masks, homemade face masks, and whether or not they work. Within this article, you can click on a testing article. So I'm going to come to that, which actually tested the efficacy of homemade face masks. And that was in 2013. And this is all, I think, driven by the SARS outbreak in Hong Kong, SARS-1. And they looked at several materials to evaluate the capacity to block bacterial and viral aerosols. So the viral aerosol, like the droplets in COVID-19. They only tested it with 21 healthy volunteers, which made their own face masks from cotton t-shirts, and the masks were then tested to fit more properly. So, and they isolated the cost of the healthy volunteers wearing the homemade mask, surgical mask, or no mask, and compared with several air samples so that you have that, bilateral comparison. And they basically said that although the surgical mask was 3 times more effective in blocking transmission than the homemade mask, there was some benefit of that homemade mask. Okay, so I'm not debating that. What's interesting though, when you start to read through and come through the methods and the material, which is something you should look at when you're going to cite an article to support your position, is to understand how the data was collected, how was it just statistically tested, and more of the details of what happened. So they used bacterial count was measured, and they used, it doesn't say it right here, it's further down. I'd have to go down further to the micron size, but they were larger microns that were used and tested. And here's the different mediums that were tested for each of the bacteria, and the pressure drop across the fat fabric to measure. All right, so I want to go down here to the microorganisms that they tested. So this first one right here was 0.95 to 1.25 microns. So that's good. That's like within the size of COVID, right? And then here, the second one, I'm not seeing, here's the measurements, 1 to 1.3, 0.2, 0.2 to 0.5. Okay, so 0.2, which is 0.2 to 0.5, that's bigger than COVID. So I would say that tuberculosis would not be a good measurement to compare with COVID. Potentially the first one would be within the measuring. And then we go further in, we're looking at them using the cotton t-shirt as the primary test. And they're talking a little bit more in details and the efficacy. So an enclosed 0.5 mobile sampling chamber or cough box was constructed for the purpose of sampling aerosols, droplets from healthy volunteers, was placed in a 22.5 meter high frequency particulate air filtered environmental room. 4 settle plates were placed in the cough box to sample for droplets, together with 6-stage Anderson sampler, and separate small particles. They coughed twice in the box for 5 minutes. And they had to evaluate the mask fit, filtration efficacy. So the results, all the materials tested showed some capability to block the microbial aerosol challenges. In general, the filtration efficacy for bacteriophage MS2 was 10% lower than the second one. The surgical mask has the highest filtration efficacy when challenged with bacterial MS2, followed by the vacuum cleaner bag, but the bag's stiffness and thickness created a high pressure drop across the material, rendering it unsuitable for face masks. Similarly, the tea towel, which is a strong fabric with a thick weave, showed relatively high filtration efficiency, but pressure drop was also measured. The surgical mask showed the highest filtration. Okay, the pillowcase and the 100% cotton t-shirt were found to be the most suitable household materials for improvised face masks. The slightly stretchy quality of the t-shirt made it more preferable choice and a better fit, although doubling the layer of the fabric increased the pressure drop measured across. And then let's see, further down. And they have a fit test here. And then here's the results of the no mask, homemade fat mask. Let's see what's going on in here. Sampling method. I don't understand fully the statistics. I admit it right here. I don't know where the micron capability was. I found it here earlier. So the surgical mask was found to be generally more effective in reducing the number of microorganisms expelled through than the homemade mask, particularly in the lowest particle sizes. The number of microorganisms isolated from coughs in healthy volunteers was generally low, although this was varied across the individual sampling. Particle diameter. Okay, so here, this is where you want to know COVID is going to have to be here. Homemade mask versus surgical mask. Anything up here is pretty much irrelevant because the particle diameter is larger than COVID, so we can't do a side-by-side comparison. So for me, just peeking at this data, it really shows me that your surgical mask is going to be better, more effective. Your homemade mask is going to be less effective, and of course, no mask is not going to stop that, right? But that's interesting to me. So, and then there's the whole debate here that you can go through. Okay, then we have another article that's cited from the Eikenberry research for justification. So what I'm kind of looking at some of the support articles from the review from like Eikenberry and why they're justifying the use of face masks or no use of face masks, whatever your bias is here. This is from Hong Kong study, the SARS outbreak there. And right here, well, there's a couple paragraphs here I wanted to point out. The variables related to social contacts with medical personnel or hospital visitors with persons with influenza-like symptoms, with persons living in a housing estate with reports of SARS patient were not significant. These findings should be interpreted with caution. On one hand, these patients could not be stigmatized. On the other, the results may have been confounded because the SARS cases contracted this way were excluded from the analysis. However, confirming that these variables could not account for transmission of the undefined source case can be useful. Evidence does not indicate that frequent visits to crowded places were associated with higher likelihood of community-acquired infection. This finding may remove panic that arose during the epidemic, and daily life need not change as much as it had. Hong Kong is a densely populated city and has a large number of SARS cases. The number of community-acquired cases in less populated cities should be much lower than that of Hong Kong. This finding should interpret with care that less than 90% of the general public wore face masks in the public places and less than 85% avoided visits to public places during the epidemic in Hong Kong. So this is part of my point, is that the research also supports that we don't need to wear face masks in open, crowded places. And that's what it seems like everybody's freaking out about. We now have some empirical evidence to suggest that wearing a face mask frequently in public places, frequent hand washing and disinfectant in one's living quarter were effective public health measures to reduce risk of transmission. So to flip-flop that, you can argue that some of the things that we place, but it's still controversial. The effectiveness of face mask use was controversial. In another study, the prevalence of these three preventative public health measures increased significantly. These practices played an essential role in limiting the spread of virus in community Hong Kong. Let's look at the fact that we're talking about face mask use with hand washing disinfecting of the home environment, minimizing exposure at hospitals and other places that have the potential and the contaminants. We are not talking about day-to-day life. And let me just scroll up to the beginning of this article. It's actually a larger sample size, so that was nice to see. They had almost 1,200 patients, excuse me, that they drew on. And the previous one I showed you only had 21, so a much smaller sample size. So this offers a little bit more support for this article, which is within the review of the Eikenberry. So I have not dove yet into every article supporting in the literature review, and that's really what it would take for us to, and then to come together as a group and a consortium in the field to discuss these different implications. But my field is very high contact. I hold people's heads all the time. I am not comfortable with the face mask myself as a practitioner. I've been playing with it, and I don't see myself working 8 hours a day wearing a face mask. It's just not going to be healthy for myself. So it begs me to ask the question, what are we to do? Also, people are talking about measuring temperature, using oxygen measurements to see if they can identify whether or not people have symptoms. But again, that creates discrimination. I have lots of clients who have other underlying health conditions that would show up with low oxygen and potentially fever, who would not have COVID. They've been self-isolated for months. So that's not a good prevention tool. And we're looking at so many other things and ways, but we've already practiced universal precautions and ways of cleaning between clients. And there are details about how long like bleach or hydrogen peroxide and the percentages and other forms that are used need to be left on the surfaces. There are also a bunch of other kinds of things that can be helped to support, but there really is no 100% prevention. So to me, we have to talk about the choice to live in fear and panic and avoiding situations, projecting your ideas onto others, what you think is right, or we can choose to live and know that we're going to be living with this virus. It is not going away, and we need to find a way to live life, open up our businesses, and live together with touch, human connection, or you can live in the apocalypse. Stay at home, live in fear, and not go out. That's your choice. Namaste.